This is what we call an anterior-interior chain of muscles. You have two. You have one on the left and you have one on the right. Diaphragm starts it off. The diaphragm comes down and attaches to the front of your spine. The right diaphragm goes lower than the left, by the way. It attaches 1 to 1.5 levels lower on the right side of your body than the left side of your body. It comes down and it attaches to the psoas muscle. So where the psoas begins on the spine, the diaphragm crural tendon is ending. So they attach to each other. So for those patients of yours that you're trying to get those psoases to let go, we're going to teach you how respiration is going to help. Because once you can teach your patients how to breathe properly with their techniques, that whole chain of muscles is going to relax because they're all attached to each other. The psoas attaches to the iliacus on that lesser trochanter. Your TFL and your iliacus attach to each other on the pelvis, and then the vastus lateralis and bicep femoris attach to each other down the lower extremity, and then we have the iliotibial band that we'll discuss. So you have a left anterior-interior chain. I've been asked in courses, can you say it versus the acronym? And I'm going to try and do that as much as possible, but I'll probably default into the left AIC. So when I say left AIC, I'm referring to this chain of muscles on the left side of the body. You have a right AIC chain. For the purpose of an intro course, the left AIC is your dominant chain that you need to inhibit. Consider your right AIC chain of muscles as the chain that you need to facilitate. I like to also refer to the AIC chain as the swing chain. So when we're walking forward, we want this chain of muscles active when we're swinging a leg. That's desirable. That's good. When I go to the left side and I put my foot down, I want my left AIC chain to be inhibited right now so that I can activate what chain? My right AIC. I need my right AIC to be able to swing my leg forward. I need to be able to shift over to the left side, whether I'm walking, playing golf, throwing a baseball, swimming in a pool, working out. It's got all kinds of application. Okay, so normal, let's talk a little bit about the patellofemoral joint. This was like my early career. Like everybody had anterior knee pain. They still do, by the way. How I approach it is different. Because that is a normal, neutral pelvis and FA joint. So that little sesamoid bone of the patella is right in the groove. It's desirable. Normal is the word. Now, watch what happens when a pelvis changes position and the femur orients in. Where did the patella go? Did it stay in the groove? No. So, historically we call this patellofemoral syndrome. But doesn't it make more sense that the femur is guiding that patella? More like femoral patella syndrome. So if you tape kneecaps, fabulous. Guide them, but neurologically, that tape's not going to do it if their proximal structure is not in the right position. Because that little, Dan's going to talk about this with the quad talk, the sesamoid is going to go, patella, wherever the quad tells it to go. And the quad is going to be influenced by what? The pelvis. So it's all like a domino effect, if you will.
At the top of page 17 and the top of page 18 are going to be talking about the left side of the body. And the lower part of page 18 into page 19 will be talking about the right side of the body. So if we talk just about on page 17, talking about the left side, patients who present in this left anterior-interior chain, and they're positioned in a state of right acetabular femoral internal rotation and left acetabular femoral external rotation. Just as a review again, we're talking about the common human pattern, which is the left pelvis going into acetabular femoral external rotation. If you want to think of that as an anterior pelvic tilt, that's fine. Flexion, abduction, external rotation, triplanar movement. On the right side, that's acetabular femoral internal rotation. If you want to think of that as a posterior pelvic tilt, that's fine too. Extension, adduction, internal rotation. Okay, so that's the AF, ER, AF, IR. This whole thing then is called the left anterior interior chain because it fosters left swing phase, which then gives you right stance. Okay, just a review from this morning. So given those relationships, if we're interested in being able to get the left side to do something different and better, like let's say the opposite of the pattern, that left pelvis is positioned in the state of that, like I talked about before, acetabular femoral flexion, abduction, external rotation. That's kind of spelled out on page 2. But what you're going to see, because of the gait cycle, you're going to see compensatory femoral activity, compensatory femoral external rotation activity. Now, that's compensation, and that's okay. Because let's talk about the gait cycle for a second, just for a second. As you're in swing phase, and let's say your left leg in the left anterior interior chain is swinging forward, preferably you'd want to have your left femur in some kind of external rotation. A ton? No. But more ER than IR, preferably, and the reason for that is, in order to do heel strike, you need to land on the lateral aspect of your calcaneus. Well, it's easier to do that if your femur is swinging forward in some external rotation moment. Okay? So this compensatory thing for the left femur isn't a big deal. Is the femur following normal mechanical constructs? No, because the left femur is in swing phase. Because now we're layering muscles on top of this whole thing. Once the muscles get involved, normal joint mechanics sometimes get compromised, which is not a big deal. That's normal. Here's what's abnormal. Okay? Left swing, right stance, left pelvis goes forward, left femur in some kind of external rotation. Okay? Then you land on it, and then you stay there. Okay? That's a problem. The thing you don't want to do, the thing that you should work with your clients and patients on, and you individually, is you don't want to stand on a femur that remains in external rotation. Because now we're compromising the hip ligaments that Jen just got done talking about.